Pneumoperitoneum from a gastric perforation. First, a pneumoperitoneum is pneumatosis, an abnormal presence of air or other gas in the peritoneal cavity, a potential space within the abdominal cavity. The most common cause is a perforated abdominal organ, generally from a perforated peptic ulcer, although any part of the bowel may perforate from a benign ulcer, tumor, or abdominal trauma. A perforated appendix seldom causes a pneumoperitoneum. Here we have an example.
Here we have a CT scan of the abdomen. Again a CT scan because this vertebra and these ribs, the bones are white, so it's a CT scan. This is a non-contrast CT scan because this is the aorta, which is grey and it is not white. In a contrast enhanced CT it would be white. So a non-contrast CT of the abdomen, and the arrow points here to this area. So this is the black area. We know that black on a CT or a X-ray is air. So this is pneumoperitoneum. Actually this is a tension pneumoperitoneum because it is displacing the organs. So this is the liver, which is pushed posteriorly. This is the spleen on the left side, it is also pushed posteriorly. So this is a tension pneumoperitoneum displacing the organs. So the correct answer is option C, that is pneumoperitoneum. If we have a look at the X-ray of this patient, we see here that this is the black area corresponding to this black area. We see the black area here and on the left side also, and this is the liver and the spleen which are pushed by this air. That is why tension pneumoperitoneum. So this is not pancreatitis because in the CT abdomen this is the pancreas, which is normal. Surrounding this pancreas also you see this black areas, so the air is reaching there also, and you see the black air here surrounding the IVC also. So the correct answer is option C, that is pneumoperitoneum. Remember that in a CT scan, pneumoperitoneum would be seen anteriorly because the patient lies supine. So the anterior part becomes the non-dependent part where the air comes and settles down. So anterior pneumoperitoneum.
Now the applications in medicine. We have a case. 2.5-year-old boy was brought to the emergency department after he had a seizure during a febrile upper respiratory illness. An adult who witnessed the seizure was concerned that the boy had stopped breathing and initiated chest compressions and rescue breathing. The boy regained consciousness after approximately 1 minute. In physical examination, he was awake and interactive, and a neurologic examination showed no deficits. He appeared uncomfortable and his abdomen was distended, tympanic, and tender. Radiography of the abdomen showed pneumoperitoneum. No rib fractures were noted. Exploratory laparoscopy revealed a perforation on the posterior wall of the stomach, without intraperitoneal fluid or other small or large bowel abnormalities. The gastric rupture was thought to have been caused by bore trauma from acute gastric distension during the resuscitation attempt. The perforation was repaired surgically. He recovered eventually from surgery and the upper respiratory illness. At a follow-up visit 6 months later, he was growing and developing well. And we have a case right here.
Pneumoperitoneum is the presence of air or gas in the abdominal cavity. It is often seen on X-ray, but small amounts are often missed, and CT is nowadays regarded as a criterion standard in the assessment of a pneumoperitoneum. CT can visualize quantities as small as 5 mg cubed of air or gas. The most common cause is a perforated abdominal viscous, generally a perforated peptic ulcer, although any part of the bowel may perforate from a benign ulcer, tumor or abdominal trauma. A perforated appendix seldom causes a pneumoperitoneum. In the mid-20th century, an artificial pneumoperitoneum was sometimes intentionally administered as a treatment for a hiatal hernia. This was achieved by insufflating the abdomen with carbon dioxide. The practice is currently used by surgical teams in order to perform laparoscopic surgery. Causes: perforated duodenal ulcer, the most common cause of rupture in the abdomen, especially of the anterior aspect of the first part of the duodenum. Perforated peptic ulcer, bowel obstruction, ruptured diverticulum, penetrating trauma, ruptured inflammatory bowel disease, necrotizing enterocolitis pneumatosis coli, bowel cancer, ischemic bowel, steroids, after laparotomy, after laparoscopy, breakdown of a surgical anastomosis, bowel injury after endoscopy, peritoneal dialysis, vaginal insufflation, colonic or peritoneal infection, from chest, non-invasive PAP can force down duodenum as well as down trachea. Differential diagnosis: subrenic abscess, bowel interposed between diaphragm and liver, and linear atelectasis at the base of the lungs can simulate free air under the diaphragm on a chest X-ray. See also, football sign, Wriggler's sign, references, Ali Noaz Khan. eMedicine.com, Pneumoperitoneum, necrotizing enterocolitis bugs, drugs and things that go bump in the night, sexual activity as cause for non-surgical pneumoperitoneum.
And now the pros and cons. The pros depends on causes. Usually a surgical consultation is indicated when we have a pneumoperitoneum. And the cons, a spontaneous pneumoperitoneum is a rare case that is not caused by an abdominal organ rupture. This is also called an idiopathic spontaneous pneumoperitoneum when the cause is not known. Causes of an spontaneous pneumoperitoneum with no peritonitis include a barotrauma due to mechanical ventilation and a tracheal rupture following an emergency intubation.
Pneumoperitoneum in human constitutes an essential app for laparoscopic surgeons. This application allows for the choice between two types of approach: Verus technique and open technique for pneumoperitoneum. In this case, we chose the Verus technique. At the bottom of the screen, you can see the toolbar, where the help option is available if you need it. Here, you can also enable or disable the sound effects. On the other hand, if you have any doubts, the information command indicates which step should be performed next. At the top, you can see the number of steps necessary to complete the procedure and the step that it's being carried out. On the left side, you have the equipment available to you. To start the pneumoperitoneum maneuvers, the information icon indicates the need to perform a mini laparotomy, which should lead you to choose the scalpel on the left-hand menu in order to make the incision. For the second step, the Verus needle is selected and introduced into the abdominal cavity. In the third and last step, the insufflator is chosen and connected to the needle, followed by control of the appropriate pressure on the right hand selected. In the same manner, you are able to perform pneumoperitoneum with the open technique.
And now this issue applied in Ecuador. When presented, in most cases it reflects a serious abdominal disease and it requires numerous imaging tests or even urgent surgery, to the possibility that this finding is a reflection of a possible perforation of hollow viscera. In the conclusions, in the presence of pneumoperitoneum, it is essential to carry out a detailed clinical history, carrying out a complete differential diagnosis to discern if we are faced with a serious pneumoperitoneum subsidiary or urgent surgical treatment, or on the contrary, only a small percentage of these cases, like a 3%, the evolution can be complicated and evolve towards septicemia, hemorrhage, or perforation, being the last surgical treatment necessary.
This is an example of pneumoperitoneum on abdominal x-ray, and in this case it's a very large pneumoperitoneum. There's a tremendous amount of free air in the abdomen, and what you can see, it's outlining the bowel, it's outlining the falciform ligament and the dome of the liver. There's so much air there, like for instance in the cecum, which you're seeing there in the right lower quadrant, you're not only seeing the air within the cecum, but you're seeing the outer edge of the wall of the cecum, and that shows you that there's air also outside. Sometimes when you have a massive pneumoperitoneum, it gets overlooked on x-rays because you're used to seeing a small amount of pneumoperitoneum on an upright x-ray or a lateral decubitus x-ray, but when you have this much pneumoperitoneum, especially on a supine film, you need to be very careful that you don't miss it. Whenever you see the outside of the bowel, or you're outlining the falciform ligament or the organs, you have to think that this could be a massive pneumoperitoneum.